Quick question before we get started with the show. Do you order lab tests from companies like Dutch, DSL, Genova, or Vibrant America? Hi, I'm Dr. Carrie Jones, Head of Medical Education at Rupa Health, the absolute best place to order, manage, track, and get results from 30-plus lab companies all in one place. Practitioners using Rupa Health are saving well over 15 hours of admin time each week for their lab ordering process. With just a few clicks, you can order from 30-plus lab companies, that's over 3,000 tests, for free in one single portal. That means one invoice for all labs, paid online up front. Plus, patients get practitioner pricing and receive full patient support through easier personalized collection instructions, automated follow-ups, super bills, answers to testing questions, and so much more. Go to rupahealth.com to sign up for your free account today. Now, let's start the show.
Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being. Our host for Redefining Medicine is Dr. Erica Schwartz. For more than 20 years, Dr. Erica has been at the forefront of advanced patient care, taking the best from conventional and integrative medicine and applying them to prevent disease. Dr. Erica is a distinguished A4M faculty member in disciplines ranging from hormone therapy, peptide therapy, and IV nutritional support.
Hi, welcome to Redefining Medicine. Today we're honored to welcome Dr. Leon Schurgers. He is a renowned researcher in biochemistry, and he's from the University of Maastricht in the Netherlands here, and I feel really privileged to talk to him about his research, which is on vitamin K and its effect on atherosclerotic changes in the vessels. And then he's going to tell us more about the difference between K1 and K2. So help me welcome Dr. Schurgers. Thank you, Dr. Schurgers.
Thank you.
Thank you. It's so exciting to have you here.
Yeah, it is. It's beautiful to be here in America.
So let's start by talking about your journey into how you got to vitamin K, vitamins, how you got involved with vitamin K, and because you're a biochemist and you know
Yes.
a lot more than any of us put together.
So I was a student and getting a job in Maastricht University at the Department of Biochemistry. And from the old days, biochemistry was focusing on blood coagulation. Right. And many factors in blood coagulations are vitamin K dependent. So that is how I got involved in vitamin K. And by the time that I got my position in 1995, it was that I started into Maastricht University, there were a few proteins discovered that were not related to blood coagulation. They were vitamin K dependent, but had a role in mineralization, either in bone mineralization or in the prevention of mineralization in the vessel wall. And so that became my topic, and I think the rest is history.
It sounds amazing. So tell me about what causes calcification at this point, and how does vitamin K2 affect?
Yes. So when I did my PhD, which was on the differential effects of vitamin K1 and K2 to investigate their role in bone mineralization and bone health and vascular calcification and the inhibition. So that was actually where I found out that vitamin K2 has some benefits. It has a better absorption profile, it has a longer half-life. So in the nutritional range, vitamin K2 is more potent than vitamin K1. Now, what is the precise function? Vitamin K, either K1 or K2, is a cofactor, meaning that it helps activating vitamin K-dependent proteins by an enzyme, which is called the gamma-glutamyl carboxylase, and vitamin K helps this enzyme in doing so. Without vitamin K, you do not have this carboxylation or activation of these vitamin K-dependent proteins. And if you consider the human body as a supersaturated calcium phosphate bag, because calcium and phosphate, they exceed the solubility product, you need inhibitors. And inhibitors to regulate the balance between calcium phosphate so that it doesn't precipitate at wrong places. And in that respect, vitamin K helps proteins, such as matrix layer protein, preventing vascular calcification.
Okay, so is it K1 or K2? What's the difference between the two of them, please, and their effect on calcification?
Yes, so both K1 and K2 have an effect on the carboxylation, and actually more or less the same effect. However, because vitamin K2 is way better absorbed and has a longer half-life, it is not only absorbed by the liver, but also available for extrahepatic tissues such as bone and vasculature. And that is where in the nutritional range, MK7 or vitamin K2 makes the change and makes the difference. It is more available than is K1. And although both have the same function, K2 is more available, so it has a better and bigger role.
So when you go to the vitamin store, how do you know that what you're getting is K2 versus K1, since K2 works better?
It's a good question. As a basic scientist, I'm not that often going to the vitamin store. I always get my vitamins from clinical trials and the leftovers, so I take them. Take it
send
from
it
that.
to us.
Yes, but normally it should be labeled. So K1 is really phyloquinone. It's also from green leafy vegetables, and vitamin K2 is of bacterial origin. So it is also labeled as K2, which is standing for the menaquinones. And that can everything between MK4, 5, 6, 7, 8, 9. And if you look at these menaquinones, then MK7 has a very, very, very superior profile. Because MK4 is absorbed like K1 very quickly, but also disappears very quickly. So it has not a very long half-life. And MK7 have actually the benefit of both worlds. It's absorbed very well, but also has a very long half-life, making it a superior K2 vitamin, in my opinion.
Your opinion is what we're asking here.
Yes.
We want your opinion. So I have another question about reversing plaque formation and the role of vitamin K.
Yeah, it's a question that I often get, and so far we did not succeed yet. So you have two types of calcification, which can be in the medial layer of vessel walls, where it is associated with vascular stiffening. Right. So you get kind of hypertension, your heart has to work harder because your vessels stiffen. And then you have calcification in the intimal layer, where it is associated with atherosclerosis. Now, some old studies in animals already show that if you give high dose of vitamin K in calcified animals, you can block the progression of calcification. So with other words, if calcification is present, normally it increases because calcification, once it's there, it builds up. Right. With a high dose of vitamin K, we were able in animals to completely block that, so the progression. 2 years ago, we had a study in ApoE mice, which are prone for atherosclerosis, right. So mice that are prone for atherosclerosis, and there we showed that also there, K2 is able to block the progression. So with other words, it doesn't regress calcification, but it blocks the progression. So it stops the process of calcification. This also means that if you would start early enough, right. You probably would prevent mineralization.
Well, you took my next question here. At what point? And when you're talking about high doses, what are you referring to as far? I mean,
yes.
Per kilogram, because we're talking about humans versus
yes.
mice. So what do you mean by high doses?
So in some 10 years ago, we did a kind of dose finding study. And what we did is we gave vitamin K2 to activate and carboxylate this MGP, so which we can measure. And we choose the concentration of 360 micrograms MK7 as being the optimal dose. I have to make a remark. This dose was found in 12 healthy young volunteers. So maybe for a patient, somebody needs more. And this is exactly the same. If you take, for example, a statin, you can have 10 milligram, 20 milligram, 40 milligram, 80 milligram. And this has all been sorted out. And there's a lot of money involved because you need all this testing. For nutraceuticals, this is always the challenge because research is really expensive. And finding for every patient the personalized dose would be a challenge. But I think that one of the good things is that the World Health Organization has not set an upper tolerance level for vitamin K, so meaning it's absolutely safe. I think you can go higher for a patient.
I think that's really important because, when we give people medications, like you said, with statins, like you have doses that have been determined and that's it. And then when you're talking about vitamins, that's not the case.
No.
Then you have it's kind of a free-for-all because we have no established guidelines.
Yeah.
So that's interesting.
It's very interesting because also some vitamins, for example, vitamin A and vitamin D have a toxicity level.
Right.
For vitamin K, that doesn't exist. At least the World Health Organization has not set that. And it makes also sense because if you, for example, look at the intake of vitamin K via food, it would mean that if you would eat maybe, let's say, 1 kilogram of spinach, that would be bad for you. Which is not the case.
Would it?
No, of course not.
Of course not.
And maybe one more interesting thing to add is, if babies are born everywhere in the world, the first thing we do is give them a shot of vitamin K.
Right.
We give them, small baby, 1 milligram of vitamin K.
That's a lot of vitamin K.
That's a lot of vitamin K for a small person.
But that's for the bleeding.
That's for the bleeding. But
right.
if it is good for a baby, 1 milligram, why would it not be good for me as an adult?
Right. What about the combination of doing ADK? Because we work a lot with ADK,
yes.
right? And it's because it facilitates, they're all oil soluble vitamins. So we work with them together because you get better results as far as the bioavailability of D, essentially. But how does that work from the K perspective? Because now we know K is such an important vitamin.
Yeah. So what we showed is that vitamin K has a very unique function because it's this unique cofactor, and there's no other vitamin that can take over this function.
Right.
So one could think, okay, this single fat-soluble vitamin can do it all. I do not believe that, because if you look at atherosclerosis, if you look at cardiovascular disease, if you look at aortic valve stenosis, for example, these are multifactorial diseases. And I think in maybe, let's say, just guessing, 30% is vitamin K deficiency, but maybe 30% is also a vitamin D deficiency.
Right.
And maybe 10% is a magnesium deficiency.
Right.
And maybe 10% is in whatever deficiency. So I think we need to find optimal combinations of vitamins and nutrients, and that will be the treatment, well, at least for a personalized level.
I think that that's what we're aiming for.
Yes.
I feel like I say, it's a puzzle. We're a puzzle, right? So the more pieces of the puzzle you put together, the more likely you are to see what the puzzle represents, which is optimal health. And I think vitamin K2 is a very important vitamin. And thank you so much for sharing your brilliant knowledge with us. I'm a clinician. So at the end of the day, we are the beneficiaries. Our patients are the beneficiaries of your research. So you getting out there is really a very important thing.
So in Maastricht University, I'm a basic scientist, so I'm in the Department of Biochemistry, but in my PI group we also have people of cardiothoracic surgery and vascular surgery. So there's really a close connection between clinicians and basic scientists. And it's really the most fantastic combination as you can have.
I hope you have some internists there too.
Yes, we do have. No, seriously.
The surgeons are...
I know, but so...
They see them asleep.
Yes, yes. But many of the cardiovascular diseases are, repaired by open surgery. And so I get a piece of tissue where I isolate cells and do all my experiments. But it's very good that I go to the operation theater and really see what is the problem. Because this surgeon sees the problem and says, Leon, this is what I'm dealing with. And you can say this and this and this, but this is not the biggest problem, this is my problem. And then I can think, okay, I have to find ways how to adapt my research and to help him and help the patient.
Well, there is no better way than bringing the researcher together with a clinician. It's for the benefit of every human being.
Absolutely.
Thank you so much. I really appreciate it.
You're welcome.
Thank you.
I liked it.